Hey guys, my name is Shrey Garigaonkar, and today we're going to talk about diseases of salivary glands that are non-neoplastic. Alright, so regarding the important points, you need to mention in general about all questions an introduction, and then in this specifically we're going to talk about sialolithiasis, sialoadenitis, mucocele, Sicca syndrome, and necrotizing sialometaplasia. Right. So regarding the introduction, you want to start off with salivary glands. Like, what are they basically? So they, as you know, they secrete saliva, and there are three major salivary glands, as you know. So the first one is the parotid gland, which is the largest. Then you have the submandibular gland and the sublingual gland, and you also have certain like several numerous minor glands as well. Um, then you want to mention xerostomia. So xerostomia basically means dry mouth. So xerostomia in itself is not a disease, but it's associated with other disorders, specifically of the salivary gland. And it's also one of the most common findings in disorders of salivary gland. So over here, we've written that it's a major complication of radiation therapy and observed as a side effect of many common classes of medication, specifically bisphosphonates. Yeah, you don't need to mention that though. Um, Xerostomia may cause only dry mucosa or atrophy of the tongue papillae with ulceration. And the consequences of xerostomia is increased rates of dental caries as well as candidiasis and difficulties to swallow and speak. So as you know, saliva itself has numerous functions. So one of them is lubrication of the mouth. So this allows us to chew food properly as well as speak properly. And as you know, saliva itself also has several enzymes within it. So it has several antimicrobial properties as well. So if you decrease the amount of saliva in the mouth, this basically results in increased risk of dental caries and candidiasis as well. So the first topic is sialolithiasis. So if you divide this word into two parts, sialo, which refers to salivary glands, and lithiasis, which means stones. Sialolithiasis basically means salivary stones in the salivary gland ducts. And as we know, if you have any kind of stones in general, there's a high chance that it may lead to obstruction. So stone formation may be formed due to either high concentration of stone forming substances, so it could be high amounts of calcium or even some medications. It could be changes in pH. So if you remember, for instance, even if you have urinary stones, if you have any kind of change in pH, either increase or decrease, you can have stone formation, and that's the similar case with sialolithiasis as well. So specifically, alkaline pH of saliva leads to better precipitation of calcium salts. And the third way of stone formation is mucus and the squamated ductal epithelia. So this together with calcium may contribute to stone formation. Regarding the pathology and complications, so as we know, if there's a stone and it can obstruct the outflow, and this may lead to retention of saliva. And as a result of this, you may have other complications. So for instance, if you have a gland over here, all right, this is the opening. And if you have a gland and you have an obstruction over here, the fluid can basically build up in this region and this can grow even larger. And this is basically what will happen if you have a cyst. So as a result of the obstruction, you can have a cyst. And that basically is called a specific type of mucosa, which we will discuss later. The second type of complication that can occur are infections. So as we know, as a general rule of thumb, if you have any obstruction in any like basically anywhere in the body, it could be the lungs, it could be the intestines. This obstruction basically can lead to uh, infections because of mainly decreased outflow of saliva, and as a result of this, it can be pretty severe. So you can have infection, inflammation, and the most common causes of this are usually Staphylococcus aureus, which eventually will lead to what is known as bacterial sialoadenitis. And again, this may be acute or chronic, and if it's chronic, it will lead to a chronic sclerosing sialoadenitis, which is associated with fibrosis and scarring of the salivary gland. And as a result of this, you'll have loss of the function of the gland. Clinically, it may present as pain and discomfort. Coming to adenitis, this basically means inflammation of the salivary gland, and this has different forms depending on the causative agent as well as the duration. So you have mumps, acute bacterial salivadenitis, and chronic. So regarding mumps, as you know, mumps is infection caused by mumps virus, and this belongs to paramyxovirus family. Um, Mumps is arguably one of the more like well-known diseases of childhood, and it usually occurs in children, but less often in adults as well. So as you can see in this patient, the macroscopy basically involves enlarged glands, and these are often soft and painful. So usually it's in the parotid glands, but it can occur in the submandibular, sublingual glands as well. And in children, it's mostly self-limited, but in adults, usually like in adults or young adults and people, it can also cause orchitis, which is inflammation of the testes, with risk of sterility. It can cause ovaritis, which is inflammation of the ovaries in females. It can cause pancreatitis, and as well as aseptic meningitis. Regarding the microscopy, so as you know, it's a viral infection, so it's going to be non-purulent, and it's going to have a mononuclear inflammatory infiltrate. Specifically about the labs, the serum amylase is usually elevated, and this is usually due to salivary gland or pancreas involvement. The next one is acute bacterial salivadenitis. So this basically is inflammation due to a bacterial cause, and as mentioned before, it can be obstruction by silolithiasis or an autoimmune attack by Sjogren's syndrome, which is a disease involving the salivary glands as well as the lacrimal glands usually. Um, so apart from Staph aureus, you also have other causes as well, like Streptococcus pyogenes as well as viridans. Macroscopy is usually unilateral and rapid red swelling and pain, as you can see in this picture here. And since it's bacterial, there's usually also pus in the duct. In this case, I think the sublingual, submandibular maybe. And microscopy is usually just purulent sialoadenitis, so you can find neutrophils in the biopsy. The next one is chronic bacterial sialoadenitis. So again, this is due to reduced saliva flow for the same reasons. And when there's a submandibular gland involvement, it is known as Kuttner's tumor, which is a type of pseudotumor. Pathologically, in the macroscopy, we may find recurrent tender swelling with large rigid glands, and this is due to fibrosis. So as we know, with any chronic inflammation of most tissues, the fibrosis follows. And microscopically, you may see destruction of the acini and fibrosis as well. The next one we have is mucocele. So as mentioned, this is one of the most common salivary gland lesion and results from either blockage or rupture of the salivary gland duct. And this is associated with leakage of saliva into the surrounding connective tissue stroma. So these also are pseudotumors. Um, Epidemiologically, these can occur in all ages, most commonly in children, young adults, and most common in children. It can also occur in young adults and elderly. So mucoceles may occur because of a obstruction due to silolithiasis. However, they can also occur due to a rupture of the salivary gland duct, and this may occur due to trauma. Yeah, so regarding the pathology, there's two types of mucoceles. So one of them is called a retention mucocele. So this is actually a real cyst. And as you know, if the examiners may ask you to define a cyst, and you need to know that's basically a cyst is something that's lined by by epithelium in general. And this usually results from ductal blockage, and these almost never occur in the lower lip. The second type is extravasation mucocele. So this is basically swelling due to the mucus that has escaped from a severe duct, and it's usually due to trauma, forming a pseudocyst. So it's not lined by ductal epithelium as in a retention mucocele. So this is a nice picture that I've got from the YouTube channel Dental Mania, and so it basically allows you to see what's the actual issue with the two different types of cysts. So on the right side, we have a mucus retention cyst because there's an obstruction in this region. And on the left side, we have the extravasation cyst, As you can see, there's actually a rupture of the duct, and you have extravasation of the saliva. So regarding macroscopy of retention mucocele, so these are usually bluish translucent and can be either mucus plug or a blind cyst. And microscopically, as mentioned, it's usually a cyst. So yeah, it's lined by epithelium. And on in the second type, which is the extravasation mucocele, macroscopically, these are also bluish translucent and they're associated with swellings. And most commonly it's in the lower lip. Macroscopically, as mentioned, these are pseudocysts. So these are not lined by epithelium. However, they are lined by inflamed granulation tissue. And macrophages, in fact, can actually be found in the lining. There's actually an additional type as well, which is called a ranula, which is basically where you have obstruction of the sublingual glands, and these basically look like a frog's belly. So regarding the treatment, it's basically just complete excision of the cyst or the pseudocyst, and it's important to note that if the cyst or the pseudocyst is incompletely excised, they can lead to recurrence of the mucocele. So this is a picture of the mucocele, specifically in the lower lip over here. So this is most likely a vibration cyst. And you can see the bluish translucent structure over here. This is basically the cyst. On the right side, you have the histological cross section of it, and you can actually see this region over here, which is the cyst, which is lined by epithelium. And in the middle, you can see the mucinous material, and this over here is basically the normal gland. So that's how it usually looks like. The next one we have is Sika syndrome. So Sika syndrome is basically is associated with what is known as Sjogren's syndrome. Sjogren's syndrome is an autoimmune disease associated with destruction of lacrimal and salivary glands, resulting in an inability to produce saliva and tears. There may be extraglandular involvement as well, but for this concept, you just need to know the Sika syndrome. So regarding the mechanism, this is a type 4 hypersensitivity. So it involves cell-mediated damage, so specifically T cells, and the lymphocytic infiltration is followed by fibrosis of the lacrimal and salivary glands. And as a result of this, you also have antibody formation. So specifically, there's two types. You can have a primary type and a secondary. And primary is basically an isolated disorder. So you have, which is called Sika syndrome. So it's only the glandular involvement. And the secondary is associated with another autoimmune disease, most often rheumatoid arthritis. So regarding the clinical features, apart from xerostomia, which is dry mouth, you can also have keratoconjunctivitis sicca, which is basically dry eyes. You have something known as Mikulicz syndrome, which is the enlargement of the salivary and lacrimal glands. And macroscopically, you have epimyoepithelial islands, which basically consist of epithelial cells and myoepithelial cells, basically. And also you have hyperplasia of the ducts. It's important to note that one of the main complications of Sika syndrome is there's an increased risk of B-cell lymphoma, which is a non-Hodgkin's lymphoma, specifically of the marginal zone of B-cell type. And this presents as unilateral enlargement of one parietal gland. So it's also important to note that there's usually bilateral enlargement and fibrosis in Sjogren's syndrome. However, if there's a sudden increase in size in one of them, then this is usually a sign of B-cell lymphoma, and you should usually perform a biopsy in those cases. Um, Regarding the diagnosis, so as mentioned, there may be antibody formation. Specifically, there's two well-known antibodies in this case, and those are against ribonucleoproteins. And these antibodies are called anti-SSA and anti-SSB, also known as Rho and La antibodies. The SS basically stands for Sjogren's syndrome, so it might help you remember. And it's important for a biopsy of the lip either way. And this is mainly to examine the salivary glands for diagnosis, and as well as note the lymphocytic infiltration. And then you have a focus score, which is basically where you count the accumulation of lymphocytes. This may help aid in diagnosis as well. Finally, we have necrotizing silometaplasia. So this is basically a spontaneous necrosis of the salivary gland, acini, and it's probably due to ischemia, which leads to proliferation of squamous epithelium and squamous metaplasia. So over here, it basically looks like an ulcer, and one of the issues about this is that it may even resemble cancer, and therefore biopsy is usually done in these cases. But these are not cancers, but they may look like cancer. And so yeah, so that's all from me. Thank you for your attention.